Hello everyone, welcome to this Olea Medical Academy webinar. The topic of the day is multiparametric MRI in brain tumors that is presented by Professor Dr. Nicoletta Anzalone and Dr. Maurizio Barbera and hosted by Olea Medical. Before I go further, we can review together the functionality of the system WebEx. All your mics will be mute, but you are encouraged to participate via chat. I will submit your questions to Dr. Anzalone and Dr. Barbera at the end of their presentation in the question and answer part. So, I'm very pleased to welcome you all and introduce you to Dr. Nicoletta Anzalone and Dr. Maurizio Barbera. Dr. Anzalone is an associate professor of neuroradiology at Università Vita Salute of the Scientific Institute Hospital San Raffaele in Milan, in Italy. She is the head of the neuroradiology unit of the advanced vascular imaging in the neuroradiology department of the Scientific Institute Hospital San Raffaele. She's an expert in neurovascular imaging with a specific research focus on brain tumor imaging. She authored and co-authored over 121 peer-reviewed papers in vascular imaging and 13 books chapters mainly focused on cerebral vascular diseases. Dr. Barbera is a young neuroradiologist of the neuroradiology unit of the Advanced Vascular Imaging in Neuroradiology Department of the Scientific Institute Hospital San Raffaele in Milan. He is involved in both research and patient care activities. He is in charge of supervising and reporting of CT and MRI examination, including neck and intracranial vessels imaging, in association with the nuclear medicine studies of craniofacial and spinal regions and the central and peripheral neural system. He authored and co-authored over 10 peer-reviewed papers. So enjoy the webinar. Dr. and Professor Anzalone and Dr. Barbera will answer your questions at the end of their presentation. So please write your question in the chat. So Professor Anzalone, whenever you're ready, you can start.
Thank you. Thank you for the kind introduction. And I think that we have to thank Olea for the invitation and to this opportunity to give this webinar. So good afternoon or good morning to everyone. I don't know where you are from and from where you are joining us. So the aim of this talk is to go through the advantages of MRI being multiparametric from the conventional images, so from the conventional sequences that MRI includes, to the more functional sequences that are already part, in not all, but part of our routine job and evaluation of brain tumors. So I have nothing to disclose regarding this talk. And before starting into the treatment of this topic, I would like to remind you, maybe most of you already know quite well, but it's important that we remind that quite recently, in 2016, we had the new classification of tumors of the central nervous system. And here you may appreciate the new classification regarding how it is organized regarding gliomas. And what is the most important things regarding this classification is that there has been the introduction of the molecular components, characteristic and phenotypes of the tumors that have an impact on prognosis and on treatment. And as you may see here, that are circled in blue and yellow, are the most important and most used, and also because they are detectable, as we will see later, molecular characteristics of the glioma. So the presence or absence of the IDH, so we all know that the glioma may be divided in IDH mutant or wild type if they have no this mutation, And another characteristic less represented is the presence of the 1p19q codylation. That is more characteristic, the presence of the codylation of the oligodendroglioma. And most importantly is that this year, another new version, we may say, of this classification appeared. And the most important thing regarding this, as you may appreciate, even if it's quite complicated apparently in looking, is that we now can talk about glioblastoma, or we can include in glioblastoma all the IDH wild type. And so they are considered glioblastoma. Then apart from that, so divided from that, separated from that, are the diffuse astrocytoma that are, as we all know, in different grades, till the grade 4, so the old glioblastoma, but with the mutation of IDH. So this is just to underline the importance of this mutation, so this molecular phenotype, since we now have understood that they have a great impact on prognosis. And so this new classification underline again the importance of these molecular subtypes. And we'll come later looking at the images. So starting from very simple things, the all-day sequences that we use, we'll look how they may add to this perspective, so to the classification, to the aspect of tumors, may add power to the diagnosis. So we'll talk about the conventional imaging and then advanced imaging. So let's start with conventional imaging. So let's look together with at these two cases, different cases. So we have on the left side T2 sequences, T1 without GAD, and FLAIR images. And you may appreciate the presence of lesions that are infiltrating, that are dishomogeneous in signal, but mostly bright in T2, not so bright in FLAIR, and iso to hypointense in T1. If we look at the difference between T2 and FLAIR, we may appreciate that there is this so-called, that has been described quite recently, mismatch of T2 and FLAIR. So the case that we have seen had hyperintense signal in T2 and iso, or we may say less hyperintense signal in FLAIR. In this paper, they have demonstrated a high specificity, unfortunately a low sensitivity, but with a high positive predictive value of this sign, the sign of mismatch, in the definition, in the identification of the fibrillary astrocytoma IDH mutated and non-codeleted. In this case, we are in front of case of grade 2 astrocytoma. And so the power of FLAIR in the useful utility of FLAIR in the identification of this molecular type. If we look at this case, we may say that these are the T2 and FLAIR. You may see that there is no mismatch. So the lesion is hyperintense in both sequences. In fact, it happened to be a 1p19q codelated. And we can say more than adding another sequence like gradient echo T2, we may depict, as we may see also with CT, a small calcification inside the lesion. In fact, we know that 1p19q codelated lesion is basically the oligodendroglioma type of the diffuse astrocytoma. And this was the case of a grade 2. So another possibility to add a sequence that is a quite quick, short sequence in time, that can depict calcification that are present up to 90% in oligodendroglioma. So this is another point in favor of other sequences, conventional sequences. Then, within the multiparametric imaging, we know that the T1 with gadolinium is mandatory, especially in the diagnosis of gliomas. And here we see another lesions that apparently resemble the lesions that we have seen before. So apparently it could be a low-grade glioma. Here again, we see that there is a mismatch. In fact, it was a non-codeleted 1p19q, but if we had gadolinium, T1 post-GAD, we see that there is enhancement in one portion of the lesion. Enhancement means that there is a differentiation, damage of the blood-brain barrier. In fact, it was a grade 4. Grade 4, non-codeleted, but IDH mutant. So in the very, very new classification, it's not a glioblastoma. In fact, this differentiation that is present in images in T1 post-GAD with the enhancement of the portion of the lesion is one of the characteristics of a high-grade lesion. Here I listed I represented the characteristic in histologic characteristic of high-grade lesion. So the cytological atypia, mitotic activity that you may see in the circle, glomeruloid and vascular proliferation that in partly may explain the enhancement and the necrosis of high-grade lesions. Then we come to another sequence that may add very important information regarding tumors, and this is diffusion. Diffusion and the map of ADC. Diffusion is related with, when we talk about tumors, to the hypercellularity of the lesion. Here is a lesion that is centered in the posterior fossa, in the fourth ventricle, in a child. And you may see that the lesion in T1 is ISO and ISO-hypo in T2. This is also related to hypercellularity, but most importantly, it is characterized, and you may see here in the ADC map, by hypo ADC with a low value of the ADC and scarce enhancement or dishomogeneous enhancement. There is this paper that is quite recent that reported a cutoff of 0.98 of the ADC in discriminating between medulloblastoma and ependymoma, in the sense that the medulloblastoma has a lower ADC. In fact, here you may see a lesion that is very similar to the one that we have seen before, despite the presence of dishomogeneity in the T2, so less hypointense, and especially in ADC, the appearance is not so hypo, but is more dishomogeneous and in some way hyper here. So the values were higher than the 0.98. So diffusion is very important in the diagnosis and the analysis, we may say, of the type of tumors. Again, in this lesion, for example, that is a lesion that is quite similar in signal to the CSF that you may see here. This is the arachnoid cyst. This is a lesion that has a mass effect on the mesencephalum and is extraparenchymal and is medial to the temporal lobe. But in the signal, you may see that is quite similar also in FLAIR to the CSF. But look at diffusion-weighted images is restricted. In fact, it's not arachnoid fluid, it's not an arachnoid cyst, but it's an epidermoid cyst that is full of keratin. And for this reason, it determines, it affects the diffusion of water molecules. So again, it's very important to obtain these sequences. And here I'm I decided to put some images from different cases in which you may see how the diffusion sequence may behave in a different way. So in the top you have T1 postgad of a glioblastoma, of a metastasis, of a lymphoma that is quite highly enhancing, or an abscess. Especially if you look at the abscess, it's quite difficult to say that it is an abscess and not another lesion, cystic lesion with enhancing. But look at the diffusion. This is the ADC map. This is diffusion weighted. And look at how it is restricted here in the abscess homogeneously. So a very good point for diagnosis. And also in some way in lymphoma, where we know there is hypercellularity. And so we go again in favor of the restriction of diffusion. Diffusion is very important it is important to look at also in gliomas, to look if there are areas that are more cellulars. That is related to a possible, within a lesion, it is may be related to a possible more aggressive part of the tumor. Look at this case of it was a young lady with epileptic crisis. She showed up with this MR that showed a very small lesion, cortico-subcortical. Look at FLAIR. They are both hyper-intense lesions. So remember the 1p19q codeletion. And it was non-enhancing at that time. And at ADC, it was possible to see that there was a component inside of the tumor that had a low ADC, so very suspect for this reason, also because in suspicion of a low-grade tumor, but with this kind of dishomogeneity, it is used to ask for a very close in time follow-up. And so the patient performed within 1 month, less than 1 month, an MR, follow-up MR, and you may see that the lesion in so short time developed, enlarged, and that this time a small enhancement was present, very superficial, very cortical. And unfortunately, this is the conclusion of the story. In less than 2 months, the lesion enlarged a lot, had a large enhancement, had a high CVV, and at this time there was a surgery, and it appeared to be a glioblastoma. So even with the new classification, we can say that it was a glioblastoma, so IDH wild type, grade 4. Another sequence that in the last years was announced for it's important in the diagnosis of tumors and also in the follow-up during and after treatment is the susceptibility weighted images. Susceptibility weighted images, we are in front of a glioblastoma here, so IDH wild type, deep 1 in the white matter, you may see here, quite classical in the conventional images, and SWI show the presence of multiple spots and a region with more deposition of blood products. And it has been reported that there is also a trend towards, so there is a correlation between the amount of deposits in susceptibility weighted images and grade. And in one paper, it was also enhanced this use of susceptibility weighted images after gadolinium. In the definition of the more peripheral area of the tumor, where the contrast stains more, and that are related to the boundaries of the tumor, where the tumor may infiltrate more in the apparently normal tissues. Susceptibility is also used for grading the tumor, for looking at these boundaries of the tumor mostly in GBM, for looking at the effect after treatment, because after radiation therapy, you may have also this deposition of blood products, but it may be used and very useful also in the differential diagnosis, typically between lesions that may resemble, may be quite similar, like lymphomas, primary lymphoma of the central nervous system, and GBM, or high-grade glioma. This is a typical case of a lymphoma and GBM in a typical location that both of them may have. That is the splenium of the corpus callosum, the region of the periventricular region. You may see that the lymphoma, of course, is more enhancing usually, but a lymphoma may have also necrosis, area of necrosis. This is a typical GBM with area of necrosis. The diffusion may be restricted also in GBM, also within area of necrosis, for example, and is restricted because it's hypercellular in lymphoma. But look at SWI is really very different. So in lymphoma, it's very, very rare that you may have some, and if you have some, they are very small spot of deposition of blood products, while in GBM, as we have said before, you may have a lot and quite spread. So we have seen, I hope that I have demonstrated in these cases, in a series of cases, the importance of using what we can consider normal and conventional imaging, so including diffusion. Nowadays, I think that we have to consider conventional and also susceptibility weighted images, even if not all the MR equipment in a conventional use include this kind of susceptibility weighted images, and you have to ask for it. So let's look at the so-called more advanced imaging, even if, especially for perfusion, we are using it, I think, daily in the tumor imaging. Perfusion, we know that has to do with neovascularization of tumors. We have here histology around vessels, so they include vessels of a lymphoma, of a GBM, of a metastasis from microcytoma. And neovascularization, we know that is related to the rise of number and diameter also, so caliber of neoformed vessels. And this is, has an impact on the measure of CBV, cerebral blood volume, plasmatic volume, and blood flow. But in neovascularization, we may have, not always, vessel wall anomaly and absence of the blood-brain barrier because of cellular infiltration. You have here, for example, in lymphoma. You may have also an inflammatory lesion that may be in differential diagnosis. You may have in metastasis where you do not have the blood-brain barrier. So in these cases, we have a higher permeability, and you may measure it with a K-trans. We have at our disposal two different techniques of perfusion. One is the classical T2 susceptibility perfusion imaging, the DSC, and the other one is the T1 dynamic contrast enhanced, both with the use of gadolinium. Here you may see three different cases. This is an old case where the term oligoastrocytoma was still in the classification. We now know that this is called grade 2, simple diffuse astrocytoma. And you have the map of the CBV from DSC, VP from DCE, and K-trans from DCE. In a low grade, they act similarly in not showing anything. In the glioblastoma grade 4, look at the difference. In this kind of sequence, you know that you have a lot of vessels, the cortical vessels that are present in your maps, while in the DCE, because it's not a T2, it's not related to susceptibility of T2, you may have the cancellation of these cortical vessels, and in this case, the tumor is more delineated than in this that is being very close to the cortex. It may be difficult to distinguish between the vessels of the cortex and the vessels within the tumor. So it's better delineated, it's better seen in the T1 sequence. And this is the K-trans that may show you different areas of permeability. And look at this case. This is also very interesting because here there is probably flow in the CBV from veins, the sagittal sinus, but also from cortical vessels here, very close to the cortex. But the sequence of in T1 sequence that is not affected by cortical vessels may show more easily the distinction of this area of enhancement of higher flow that is not clearly seen here because it's within all the vessels. And there is also a higher permeability. We have performed some years ago a study with the aim in gliomas, with the aim to see if there were any difference in these two kinds of perfusion related with the grade. We also included some molecular data. And we have seen that in comparing the lower grade glioma versus the glioblastoma with all the parameters, with so all the markers, and also in comparing the very low, the second grade, with the third and fourth, what we used to do there at that time, the area under the curve was similar for all the markers, so for the two perfusion. So we did not, you may see the p-value, we did not show any important difference regarding the accuracy with respect of the grade in these two perfusion. A very important notion, a very important results that was published in this paper by the group of Heidelberg this was one of the first papers, was the identification, the report of the possibility with DSC and the measure of CBV in gliomas to differentiate the IDH mutate versus the IDH wild type, being demonstrating that the IDH wild type had higher CBV values than the IDH mutate that we have said had a better prognosis. This helped us to understand some very old studies. One of the most important is a study that has been published by Menlo that reported this cutoff that I think that we all have in mind of 1.75 of the CBV in differentiation of better prognosis and versus worse prognosis of lower grade glioma. And now that we know that there is this molecular phenotype, we probably better understand that values was related, that cutoff was related to the presence or absence of the IDH mutation. We also performed a study on gliomas of second, third grade in a small group of 38 gliomas, in looking at the value of the diffusion, so the ADC value, and the CBV value in the differentiation of IDH mutated versus wild type. And you may see here the area under the curve that is quite high of the ADC, of the CBV, that had a higher value when they were coupled together. So we concluded that combined analysis of diffusion and perfusion MRI allows stratification of the lower grade gliomas based on the IDH mutation state. So this is to demonstrate the importance of these so-called functional or more advanced techniques, but they are used now in the common clinical practice when we study tumors, in the possibility to differentiate tumors with a better or worse prognosis. These are two examples of IDH mutant, codeleted anaplastic oligodendroglioma, grade 3. You may see how it is dishomogeneous. The ADC, you may see that is not so low, and the measure was 1.6 with some high CBV, but not with very high values. On the contrary, on the other side, we have another tumor that have a lower ADC. We may appreciate it also qualitatively. In fact, it was lower measuring it with a higher CBV. And in this case, at that time, after the 2016, happened to be a grade 3. But nowadays, since it had also nodular enhancement, we can consider, and it was wild type, so wild type, a GBM grade 4, as we have seen in the fourth slide. The perfusion is also important in help us in the workup of tumors when we have to make differential diagnosis. For example, between lymphomas and high-grade gliomas. Here are two examples. What we have learned is that the lymphoma, the more typical, we may say, primary central nervous system lymphoma is homogeneous in the enhancement. So the K-trans is quite homogeneous, so high permeability. We have seen that this is related with infiltration in vessels. The VE, so the extracellular volume, is quite homogeneously high. Look at here, is not so high, and it's dishomogeneous in the GBM. And also the K-trans may be different in different portion of the tumor. On the contrary, it has been reported, and we know that the values of the VP, so the plasma, the blood compartment, and the CBV are lower in the lymphoma than in the GBM. Which is the field in which we are looking more, we are expecting more from these functional techniques, and most of all perfusion, is the treatment effects on the tumor vessels. So on tumors, but basically on tumor vessels. Here we have a GBM, or we could say a diffuse astrocytoma grade 4, but IDH mutate, so related to the very new classification. Is not a GBM, but it's called like that. These happen to be MGMT methylated, so quite aggressive edema, the typical appearance of the contrast enhancement, necrosis. It has been operated on. These exams performed before the starting of the chemoradiotherapy, and unfortunately it appeared that there was a lesion around the surgical cavity, and also quite medially to that, quite far away it seemed. As we do usually, we performed a perfusion with the two perfusion techniques, so T2 with the CBV, and T1 with the measure of K-trans and VP. And the value were very high. So you may see, we also always look at the curves, and here you may see that there is a very deep drop of the signal, so high CBV, as you may see here, with also an effect of T2 leakage that you may see here, with the curve that doesn't reach the baseline. And the curve of the T1, you may see that is what we call the vascular curve. So the so-called type 3 curve, if we look at the curve biology, that is related with lesion and malignancy in the sense that is related to vascularization. And in fact, there was probably pathological tissue before the treatment. Then the patient started the treatment, so the combined treatment, chemoradiotherapy, and 2 months from starting, we look at the images and we see that there was a lesion a little bit different from the other one with more necrosis, but we were doubtful, as we are most of the time. What we see here is that the K-trans is inhomogeneous but some high, the CBV is not so high, the VP is less high, is not so high as previously, but most importantly what we do is to look at the curves, so look at the curve of the T2, yes, see there is T1 leakage, so permeability, and look at most importantly what we do in everyday practice at the curve of DCE, and the curve change is not type 3, it's probably type 1, so that is a curve that is related mostly to permeability. So we were in favor of a treatment effect, probably some pseudoprogression and radionecrosis. In fact, after 2 years, this is the picture of the patient, luckily, so a better prognosis, the lesion was related to treatment, and there is an effect of radionecrosis, so presence of coagulative necrosis and hyalinized vessels. So this is a role for perfusion that is very, very important. Another aspect, so going through quite quickly, is another functional sequence, we may say, is spectroscopy. Spectroscopy is very important for functional characterization, being able to detect the metabolites, so especially choline, creatine, and NAA. And we know that the behavior may change during the presence of metabolic activity. In fact, this is related to the normal tissue, the neurons that are present in healthy tissue, and choline is more related to the mitotic activity. Then you may measure the lactate. This is very routinely, so very normal. That is more related with necrosis. And here is just to show you how there may be a relationship between the choline-creatine ratio and the MIB1, that is the index that is related to the cellular proliferation. And it has been reported in several papers. You see here, creatine is almost not visible, so the ratio is very high in GBM. And these are other examples in which you may see how this ratio, that is the most important, but look also at the NAA that drop in very high, going upper with grade, but this is the ratio that we usually look at. And then you may have measures also of the necrosis. That is another through the measure of the peak of the lipids and lactate that is related to necrosis, that is related also, is present also in high-grade glioma, but lipids may be present also in other type of tumors, for example, like lymphoma, and you may see here that the peak of lipids, it's quite diagnostic in the suspicion of lymphoma, and it's better to be measured with low TE sequences. I'd like just to mention two very quite new introduction in the functional imaging. And one is the spectroscopy that has to be performed at 3 Tesla, that may measure the 2-hydroxyglutarate. The 2-hydroxyglutarate is related to the mutation of the IDH1 probably that more represented and that we have seen before. We have talked about it. So you have to know that these metabolite may be measured, it is correlated to the presence of the IDH1 mutation. This may be measured with two different kinds of sequences of spectroscopy, and they both have reported a high sensitivity and specificity in the identification of the IDH mutation. And this is it's quite relevant. This is a pioneer a paper that has been published by the group of LA in 2012, in which they, in a few cases, demonstrated that in the IDH1 mutant, they both are cases of grade 3, there was the possibility with these sequences to detect the 2-hydroxyglutarate with a high specificity and sensitivity. So being able to give a diagnosis of the molecular type that we have seen has an impact on prognosis and is important also for treatment in vivo. This may have an importance in the especially in cases where you may not be able to perform biopsy so quickly or so easily, for example, in very deep tumors. And lastly, another promising sequence. This is a different sequence. This is a sequence that reminds me the magnetization transfer. It's so-called the chemical exchange saturation transfer imaging. And this sequence detect essentially, it has to be performed at 3 Tesla, and it's able to detect some molecules that basically are amide, amine, that may exchange hydrogen protons. And these amide, amine are mainly, they are endogenous and they are mainly products of proteins. And these are mainly present in tumors than in normal or healthy tissue. So an application of this kind of sequences is the differentiation, for example, of tumors versus tumors. It has been also applied again in the differentiation of different grades of gliomas. But to me, the most important thing is again the role in treatment effects. So differentiating from treatment effects like radionecrosis to progression of disease. And here is the case that comes from Paris, Dr. Nicoletta, and you may see a case from the publication that appeared in Current Opinion in Oncology recently. This was a case of a lesion, metastatic lesion, I think of breast cancer, and that has been submitted to gamma knife radiosurgery. At a certain point, you may see here that there was a lesion, slightly edematous, with some deposits that we have seen that may be related to radiotherapy. ADC was high, no CBV, so the idea was that it could be a radionecrosis. But with these sequences, there was a raise in the high signal in the APT sequence. So saying that there may be some amide proton transfer, so amide, so related to the presence of proteins, so tumors. In fact, after 3 months, unfortunately, there was the appearance of the lesion. So the lesion that was a relapse of the metastasis. So this is appears to be a promising sequence. We have to have some more results from a large study, I think. So with this, I want to conclude. I think that I hope that I gave you the show from the more conventional sequences to the more so-called advanced one, how MR is still really very multiparametric, and this concept that is intrinsic in MR is of particular importance in the diagnosis, but also the follow-up, I would underline this, of brain tumors. And I thank you very much for your attention. Thank you.
Thank you very much, Dr. Anzalone. That was a brilliant presentation. So I'm really impressed with all the MRI techniques you have covered in such details. And so we have some questions for you and Dr. Barbera. So the first one is, okay, thank you for this outstanding didactic talk. Do you believe that with emerging techniques, advanced multiparametric MRI could in the future replace a biopsy, knowing that brain tumor biopsy is sometimes lethal?
I think that this question is for me, that I'm older, so I have a more broad view of okay. And I'm not sure of that, because I think that biopsy is important for the treatment, is mandatory also for the treatment of many tumors, for example, lymphoma. Nowadays it's like that, but it is possible that probably is not in a very, very near future, but it will become less used, or probably all these sequences will help us in these more difficult cases in which biopsy becomes to be more dangerous or more harmful for the patient. I think so. So we can think about it a little bit more when facing the possibility that the biopsy is may be harmful to the patient. I would think in this case. Maurizio, if you have other ideas around this?
Yes, hello. You have always to consider that there is the inherent risk to miss the right target in a heterogeneous tumor when you perform a biopsy. So imaging, I think, is nowadays essential to, especially advanced imaging, essential to highlight the correct target, the so-called hotspot. I think probably could be important for tumors, for example, of the brainstem that are very difficult to be targeted with surgery. Advanced imaging could be a good choice.
Okay, that's interesting. So thank you very much for both of you. And in complement of this question, we have another one. What about liquid biopsy? How can it complement multiparametric MRI in differential diagnosis?
It's also to me. In several conditions, you may use liquid biopsy. Again, I'm thinking about lymphoma, but at present it's not definitive. So you don't have to, you still need the histology.
Okay.
At the moment, yes. At least in most of the tumors. Brain tumors. Mm-hmm. Maurizio, you want to say something?
Yes, I agree. Histology is a paramount. Liquid biopsy, I think it could be just a tool to assess the tumor, but I think it's very difficult to not to rely on histology.
Now, I think I would like, if I can add something to the reply that Maurizio gave to the first question. I think it is really important images in the definition of the, as he called, hotspots, pre-biopsy. So with this perspective, the more we add with this advanced technique in the identification of a more proper point for biopsy is very important, because we know it from studies, we know from the everyday practice that sometimes biopsy may be not conclusive because the exact point was not the point of the most aggressive part of the lesion. And it happens not so frequently, but it may happen really. So this is a good point that has to be underlined and well known by everyone.
Okay, thank you very much for this very interesting information. And we have other bucket of questions. So thank you very much for this complete and comprehensive talk. Can you discuss the effect of different therapeutic agents such as corticoids or antiangiogenics in radiological characteristics?
There should be a lesson, a talk to cover all these topic. Do you want to say something, Maurizio? And then I can add if.
Yes, we can
topic.
broadly distinguish, for example, the so-called pseudo progression and the so-called pseudo response. Pseudo progression is typically it was first described in glioblastoma after temozolomide plus radiotherapy, especially the treatment with temozolomide. So this apparent progression, but this is not real. It's just a type of inflammatory reaction, okay? Instead, while pseudo response is described as the apparent reduction in enhancement after antiangiogenic therapy, okay? Such as bevacizumab, okay? You see a progressive reduction enhancement, contrast enhancement, but an increase in FLAIR lesion, in the FLAIR portion of the lesion, that is the vital, okay, the vital portion. So you have in reality a progression of disease. I would like to, for example, among this type of pseudo response, there is definitive, a class of tyrosine kinase inhibitors that cause a peculiar type of pseudo response in which you have a very strong reduction in diffusion signal on IDC map. Okay, it is very peculiar of this novel kind of drug therapy.
Sorry if I interrupt you, but to underline the usefulness of this advanced technique in the measure of, in the follow-up of antiangiogenic therapy, diffusion is the most important, together with FLAIR, because of the effect of on the blood-brain barrier and the scarce enhancement, basically, more than perfusion. And if the question also included the effect of corticosteroids. Of course, the effect of corticosteroids, if they affect the blood-brain barrier, as we know, may affect also perfusion parameters. And yes, it may.
Very good point.
Perfect. So, thank you very much for this detailed answer. So I have also another question. So thank you very much for your great talk. In your presentation, you have shown us the effectiveness of the tissue FLAIR mismatch to identify with a specificity of 100% the EDH mutant 1p92 non-codeleted gliomas. What physiological characteristics of this specific tumor type do you think generates this mismatch in the signal? Since this mismatch is strong in highly liquid components, such as the cyst, do you think these tumors also have a liquid component?
I looked through. Thank you for the question. Do you vuoi rispondere? What do you want to?
I think yes, yeah. Authors think it depends on the a peculiar subtype of fibrillary astrocytoma called gemistocytic, or protoplasmatic astrocytoma. That means you have a relatively large cytoplasm of this cell, so you have a relatively swollen cell, okay, among extracellular matrices, so you have an intrinsic higher water content, okay, so you can have a drop of a signal in the FLAIR images due to this high intrinsic high free water, okay, content, also intracellular and extracellular.
Yes.
Oh, okay.
Perfect.
So, Dr. Anzalone, do you want to add something?
No, I just want to add a general concept that, and to thank for the question, because it's a very good point. And because when we look at images, also very common and apparently basic conventional images, they are really, we have always to think about the pathological condition that is underlying the images. So this is, I appreciated the question because it's good. It's good to think that a behavior in the sequences has to be related to an anatomopathological condition of the lesion, especially when it includes more cases, so it's repeats in it is repeatable.
Yes. Thank you very much. And we have the last two questions. So we'll start maybe with because they are very interesting, and I think that the answer could be maybe a long one. Let's see. So, what do you think about all the post-processing tools that are being developed on top of new MRI sequences, deep learning, AI? Are they already useful in clinical routine, or will they be?
This is a broad question, so it's difficult to answer because I think that we are a little bit far away. There are two different steps. One is the application in the common routine, so identification of lesions, so lesion detection, for example, measuring of lesion. This is a level that help the clinician, the radiologist in his daily work. So I think that we are quite close to have something that is very useful, but not so perfect at the moment. Then there is another level that is the level of the research, where we use these tools to facilitate our analysis. So segmentation of lesions, for example, is very easily provided now with these systems, and so it's easier for us to do all these kind of study on radiogenomic or on correlation of the lesions and other parameters. So I think that we improved a lot, so thanks to all the researcher, and we'll have in the near future many results on that. Do you want to add something, Maurizio?
Those advanced images techniques are not perfect, but perfectable. And I think they are, for example, artificial intelligence is everywhere in our society, so it's changing our lives. Okay.
Thank you both. We have the last question. What will be, in your opinion, if you had carte blanche, the ideal MRI exam for brain tumor characterization and grading?
Carte blanche, I'm not sure.
So carte blanche.
Yes,
means
carte blanche. Yes.
Yeah.
Yes. No. This I understood, but in doing what? I didn't. I'm not sure to have understood the whole question.
Yes, let's say that if you need to pick the best, what you'll be, in your opinion, the best exams, let's say, that you should be for to do tumor characterization and grading? If you need to pick, let's say, the most useful one that you've seen so far.
So I would pick all the conventional that I showed, including SWI in tumors, and then perfusion. Then I look at the more the cyst, for example, but we need some more data.
Yes.
And probably in some cases the spectroscopy, yes, is less used. The spectroscopy for so it's very used in tumors, but it's less diffuse than perfusion because of problems that you may have with location of the tumor, for example, if close to the CSF, if it's close to the cortex or vessels, if it has hemorrhages inside or post-treatment. Spectroscopy is a little bit more to be more selected in the use. Not so broad. Perfusion, to me, but not only to me, is the sequence that I would use routinely.
Mm-hmm. Okay.
Maurizio, do you agree?
Yes,
in
yes.
2 words?
I think PY is our workhorse. Okay, but I will pick multiparametric MRI as a whole.
Perfect.
Okay.
Thank you very much. And sorry, before leaving, there is the last question. Then we can close the session. So I've seen that in your presentation you have shown the usefulness of cerebral blood volume (CBV) and volume transfer constant (K-trans) maps for perfusion imaging. In your experience, also cerebral blood flow (CBF) map may lead to other information in the framework of tumor characterization, or this map is redundant to that of CBV?
It's not completely redundant. It depends if you're using we are talking about the SC, of course, and not ASL. But I don't know papers or study that, apart from my experience, that have demonstrated the usefulness of adding it in a more to help in a more precise diagnosis. So probably to me it's a little bit redundant, but I'm open to discuss it again in the future if someone brings it again on also for tumors. But if you deal with ASL, of course, you have to deal with CBF.
Okay.
I don't know if I answered the question completely. But
yeah.
Okay. Okay.
Perfect. So so we have. Thank you very much to both of you to have replied all these questions, and thank you very much for this great presentation. And so we'd like to conclude also by thank everyone here connected. So we appreciate you being here, and so see you next time, and have a nice day, everyone. Thank you.
Thank you. Have a good night. Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Or
Bye-bye.
day. Bye.